and thank you for that kind introduction. So I'll be the moderator of this session for the next hour. And as we've already said, the theme is applications for SGRT from 4D CT to planning, free motion management and dose visualization. So I think SGRT as a motion management tool is relatively well established with lots of published studies and clinical evidence. So today during this webinar, we're going to dive deeper into how SGRT can be used across that whole patient pathway, and then looking into some of the newer innovations and tools that will allow SGRT to be applied to more patients and improve the clinical efficacy of treatments. We encourage you to ask questions today, and to do that, please use the Q&A box to do that. And we're going to take all questions at the end after the presentations. If you have a particular speaker that you would like to address your question to, please just put that into the question as well, and we'll make sure that the right speaker gets to answer that for you. So today we're really pleased to have two very experienced medical physicists presenting during this webinar. And our first speaker today is going to be Josh Naylor, a principal physicist at the University Hospitals of Dorset in the UK. His special interests include LINAC QA, radiotherapy imaging, as well as commissioning new equipment, including SIM-RT and Align-RT. Josh is registered as a medical physicist expert with the RPA 2000, and he's heavily involved in education and training of new medical physicists, having completed a fellowship with Health Education England into expanding regional medical physics training. Today, Josh will talk about the vital role of surface-guided radiotherapy to ensure safe, efficient treatments from the experiences of an NHS physicist. He'll be followed by Michael Tallhamer, Chief of Radiation Physics at Advent Health, Parker, Colorado, USA. His background is in computer vision, mathematics and image processing, and serves as a physics consultant working on a variety of projects in medical physics. He is also past president of the Rocky Mountain chapter of the AAPM and has a wealth of experience with SGRT. And he's been commissioning and utilising SGRT systems in his clinics since 2008. So a good tenure of experience to share there. And today, Mike will talk about the impact of SGRT on every step from simulation to delivery. So with the introductions out of the way, I would like to hand over to Josh Naylor for his presentation.
Thanks, Menna. Hopefully everyone can hear me. You could give me a nod, Menna, if that's, yeah, good. So as Menna said, I'm down on the south coast of the UK. If you're not familiar with the geography there, hopefully you know where London is. We're kind of a couple of hours southwest. And we have two centres. One's the satellite centre, and then one is our main site, which has 3 LINACs at, just one at the satellite, all varying true beams. We've got Align-RT on all of them, which definitely is the way to go. If you want to introduce SGRT, it's best to have it on all LINACs. And we have SIM-RT on a CT scanner as well as that. That's not pictured, but just a brief intro for people if kind of not so familiar with SGRT, how it works. The different systems, one of them works in a slightly different way, but they either use this pseudo-random speckle pattern that's projecting visible light on the patient, or they use structured light. Both of those are kind of performing the same function in that they allow the surface structure, the shape of it, to be reconstructed. So the camera pods are all more or less similar to this. This one pictured is one of the Align-RT ones without the covers on. And you'll see the 2 image sensors. Now these work a little bit like our eyes do. If you want to try now, you can put one eye closed and put your fingers together and attempt to get that, touch them together, and it's much harder with one eye shut because you don't have the depth perception. So the 2 sensors on the camera pod there work in a similar way to give that depth perception. And you'll see there as well the projector that projects in the case of a line RT, this random speckle pattern, or in the case of CRAD, it's a structured light pattern, and they're both using that to triangulate that position. And the system knows what that pattern looks like on a kind of calibration or reference surface, and then it compares what it's looking like on the patient to that reference. And this allows it to triangulate each point on the patient, creating, when comparing to tattoos where you've got 3 tattoos, you're creating a surface model of many thousands of points. This is a slightly old slide. It says 20,000 there. I suspect it's higher now. So yeah, I'll just skip on to this bit. So why are we at a position where I feel, and I know Mike feels, that SGRT is an essential part of safe radiotherapy? So over the decades, we've gone from conformal radiotherapy to IMRT and then to VMAT. And with each of these steps, as you can see by the rough and ready dose distribution there, we've got obviously more conformal and steeper dose gradients, and we're kind of therefore much more at risk of treating the wrong dose to the organs at risk. So alongside that, this increasing conformity has necessitated an evolution of image-guided radiotherapy. We were originally just hoping the patient was in the right place. Then we had film come in. Some of you may remember that. And then the kind of more digital solutions for MV imaging. And then a big step change came when cone beam imaging was introduced. We installed that at my centre on some of our Linacs in around 2012, and prior to that on another one. And that gave us this soft tissue, much better soft tissue definition, and we use it now daily for almost every treatment site. And this cone beam imaging let us bring those kind of dose conformity down with the VMAT. And I would say that SGRT, and then Mike's going to talk about the dose RT, which the blue camera there is, this is as big a step change as cone beam. I really do feel that. And as well as the dose conformity improving, this has allowed us, in tandem again with IGRT evolution, to increasingly hypofractionate patients. So that previous slide was a few trials, for UK ones that have kind of expanded hypofractionation. This is real data from my centre. So for Linacs, and we treat all sites really. We just don't do SRS. So kind of think of that. Until about 2020, we were up, around 15 fractions for each treatment course. In 2020, we introduced 5 fraction breasts. That's that big drop in 2020. And then more recently, we've increasingly done SABRE or SBRT for lung and oligomets as well. So this hypofractionation, the reason I'm mentioning it is because it kind of increases the need for SGRT, because we have so much more dose per fraction, and therefore a bigger risk of getting a large amount of dose to the wrong place if the patient moves. And then looking at the benefits, I like to kind of split them out when we're comparing SGRT to tattoos and then the real-time monitoring, to separate them out into those 2 components. So we have I'll put all the benefits up so you can read them as I talk, but we have the kind of benefits over tattoos first on the left-hand side there. So one obvious thing is simply not needing to tattoo the person, the psychological impact of that. And I'll come back to that in a minute. Also, the head and neck shells, similarly, we'll come back to touch on that in more detail. And then efficiency, there's some data that I'll share in a sec, which is showing that SGRT is just much quicker because you're going to the right place instead of that kind of initial position with the tattoos. It's increased the confidence for our patients and our staff, and then the accuracy is much better. The residual shifts on the imaging are lower, and manual handling's improved. It's easier to get the patient into the position for our radiographers, therapists, RTTs. And then in the real-time monitoring part, now the kind of obvious bit is where it's replacing tattoos, but real-time monitoring is really adding something that you didn't have without SGRT. So there's massive improvement in safety there, because if the patient moves beyond a certain tolerance, it just shuts off the beam straight away. And then ability to reduce imaging dose. And then we've noticed that radiographers will choose our centre to work at because they want to work with SGRT and new technology like that. And it makes it more likely that people will stay as well. So the retention aspect of that. And it's allowed us to develop lots of new techniques, which I'll go into more detail on some of those later. So for the Tartulus aspect, this is another map of where we are. We've had patients actually travel to us from Exeter. I think they're going to be getting SGRT, but at the moment they don't. And they've traveled all the way to us, which is a 2-hour journey each way, just to have no tattoos. So that's a really good demonstration of how important it is to patients. And then the error reduction piece. In the UK, we have IRMA, the Care Quality Commission. They're the kind of regulators who deal with the laws about irradiating patients. And if you read their reports, which they release annually, they're available for free online. They're very useful when you're thinking about safety in radiotherapy. And a vast quantity of the errors in these reports would not happen if every centre had SGRT, or at least they would be strongly mitigated. On one year I counted up and it was 87% would likely not happen, because most of the errors we see in radiotherapy are that setup positioning parts, and SGRT is obviously helping that. And our error reporting, we use Datex to record it. We saw massive reductions in our errors when we went, and I used the data in that to have a look at that in more detail. And this is borne out in the literature as well. This reference is quite nice. It talks about the role in improving patient safety. It's an international document that looks at many centres, and they found about 20% of reported events could have been prevented. And people are kind of putting their money where their mouth is, and in the US, all of the top 20 hospitals for cancer have SGRT. And then in the UK, we're a little behind because the NHS has slightly less money, but 60% of the UK hospitals have SGRT, and I know that the 40% that don't are really trying to get it as soon as possible. So hopefully you're all on board with the fact that we need SGRT for our patients, and go into a bit of detail on the different options, different manufacturers. So Mike and I both have Vision RT system, that's a line RT. There's also CRAD, Identify from Varian, and then the BrainLab system. And more recently on the market is LAP, and then they're not on the slide actually because I don't know all that much about it, but Clarity is another manufacturer. So this data is largely from TG302, so that's why it doesn't have LAP on there. It's the publication date of that document, but the QR code will take you there, or just search for TG302. And there's lots of tables like this. I've updated this one a little with information from the manuals, but they're very useful documents, as well as having a lot about commissioning and quality assurance. They're very useful for choosing a system as well, and things like the LINAC interface there. You need to make sure that the system does what you want it to do, and really plan out which systems you want it to connect with and what techniques you want to use it for, and kind of scrutinize the systems that you're planning on or considering for purchase. Estro ACROP, this guideline as well, is very good for commissioning and for choosing different systems. I would say that it's worth, as I said, just scrutinizing it, because the recommendations in those two guidelines, the AAPM and Estro ACROP guidelines, not all of the manufacturers meet all of the recommendations in them. So it's good to do that due diligence. So a bit more on CRAD. They've updated their hardware over the years, and as I said earlier, they use structured light, which is a little bit different to the other vendors. There's a nice GIF there of how this works. And one of the kind of unique things about CRAD is it can project the tolerances of the patient in coloured light onto them. I mentioned about the TG302 recommendations, worth highlighting that another unique thing of the CRAD system is it uses deformable registration. So TG302 and also TG132, this document's on image registration and fusion. It's, I would guess, fairly negative on deformable registration. So it can be a bit tricky to QA, I think. So that doesn't mean you can't use it. It just means be mindful of the recommendations in both those documents if you are using deformable registration, because of course cone beam uses rigid registration. That's kind of what we're used to. So yeah, I've used this a few times. I actually went to the headquarters of Humideep before Varian purchased it. It uses a speckle pattern similar to Align RT, and their Halcyon install, as you can see there, it doesn't have the in-bore cameras, but it has one behind the gantry. The Align RT Halcyon one has a kind of ring that goes inside the bore. So yeah, as I said, we have Vision RT in a. They've developed their hardware too over the years. We've got the older camera on the right-hand side there, and then the newer Horizon one is the one on the left. One thing that drew us to Vision RT and kind of made us choose it is the number of publications out there, because they're the oldest, kind of longest running vendor on the market. They invented it. There's just been that much more time for people to use it for all sorts of applications. This QR will take you to a nice library of those publications, and that just gave us some reassurance that we weren't reinventing the wheel. There's Mike on stage. I've valued his talks a few times at the SGRT community meetings, and similar to the publications, it's just a chance to learn from other users and people's kind of passion about it and inventiveness of how to do new things. This book that is published, I would recommend buying it. It's actually vendor neutral. It's got information on all of the major vendors when it was published, and it's really useful for commissioning and other aspects, choosing a system. Another thing that we really liked and continue to like about Align RT is the training and support offer. It is quite different for your radiographers or RTTs. Stopping using tattoos, they might have used them for decades, and having this new system to work with and monitor. And it's quite user friendly, but you do need really good training. And we're all physicists on this call. So for the commissioning and then the QA ongoing from that, I would really recommend getting the proper training before you try and commission it, because it's quite different. It's not like getting a new Linac or a new water tank or something. It's just completely different kit. Just to highlight a few features of the Align RT software that we like, Mike's going to talk more widely about the other pieces of software and hardware available. So one is postural video. So the kind of original view used to have these real-time deltas on the left. That's showing you the 6 degrees of freedom. And then you'll see on the right this what's called postural video, this augmented reality kind of thing with the line drawing. And you can really use that to set up the whole patient, which is brilliant. As you can see there, the arm position and things can be helped get those arms in the right place, or any part of the patient using that. And then there's just a link to more info, but you can Google that if you want more info. Another feature we use quite a bit is send to couch. So if there's a residual error, let's say the patient moved as you're walking out the room or something like that, you can just send those shifts from Align RT actually to the Linac couch and then move it to correct that position, which is a nice feature to save going back in the room. And then if you want to continue doing SSDs, I would suggest that if you're using SGRT, you don't need to do SSDs. But if you want to, you can grab them there in the software and not have to use the ODI. And then there's also this deformation tool. This is quite nice. You can use it to look for seroma or weight gain, weight loss or things, or just troubleshoot setting up. And it will show which part of the region of interest is out of tolerance, which is a nice feature that our staff really do use quite a bit. And I put this photo in just as a kind of placeholder to remind me it's the factory. It's actually only an hour or so up the road from us here in the UK, and it's to remind me to mention how much of the staff at Vision RT work in research and development. So although they've been on the market for the longest, they're not resting on their laurels and investing a huge amount in lots of exciting new things, such as this was recently released, Beam Guide. Mike will go in a bit more detail. It's slightly related to Dose RT, but it doesn't use any additional hardware. It's just built into the Align RT software. It's an extra module. And what it does is use the treatment plan to show where the radiation is going to be delivered, kind of in a live view. So if I just click through a bit, hopefully the video will start. Yeah. So it's an enhancement to that postural video that I was just talking about. And that orange kind of shading there is showing you where the radiation is going to be delivered before it's delivered. So it's kind of like the Dose RT in that it's visualizing the radiation, but it's before we deliver the beam, which is fantastic because of course you can then detect an error of incorrect setup or wrong laterality or something like that before we've made the mistake, as it were. And then another feature that I really like is auto ROI. This is brand new. And this is meaning that we will kind of standardize our regions of interest, no matter who's making them, because it does it automatically. And as well as that, it's just quicker. So saving time for staff, which is brilliant. So it just goes through the normal kind of screens for drawing an ROI, but it has a library of them that you can apply, and you can still edit them if you want to, but it's a great starting point. Just jump through those. Yeah, so I'm going to talk a bit about respiratory gating in a few minutes, but this piece of work that I recently published, it dates back a couple of years to a method that a colleague at another hospital developed, a method for measuring latency. So latency is a really important factor in SGRT because when we detect the patient's moved out of tolerance, we want the radiation beam ideally to switch off immediately. Of course, it doesn't because there's some processing, but the quicker it switches off, the better. So I actually recently measured the latency on a whole range of vendors, all of the major ones really. And you'll see that there's quite a wide discrepancy. The kind of dark blue bars are the manufacturer's specifications. That's from the manual and information associated from each vendor. And yeah, there's a big range from 121 milliseconds there to about 400. And this was all measured with the same method, although the Brain Lab one slightly different, but actually the equivalent Align RT measurement with that same method would be slightly less than 120. Yeah, and it just shows that it's really important to measure latency and do that regularly and consider how that's going to impact on your patient's treatments. There's more in this talk. You can search for it on the SGRT community pages, or I think it's on Vimeo as well, if you want to watch more about that. So kind of thinking about QA and commissioning, when I've mentioned that specific test, again, reference you to this excellent publication, 302, and then the Estro ACROP one as well. They're both very good for all-round commissioning and QA guidance. And just thinking of those values that I shared on the graph a couple of slides ago, the tolerance in this guideline is 200 milliseconds. So if you remember, a couple of the vendors were over that tolerance. Although I did hear recently that this 200 milliseconds is actually just the SGRT component, whereas my method measures it end to end. So, but still, they would likely be over that tolerance, which is something to keep in mind when choosing a system. So, yeah, as I said, with latency measurements, that's very important if you're doing gating. So that's something we're currently introducing for our lung patients. Previously, we always had done this motion inclusive, or ITV as it's normally known. And then with SGRT, we've introduced breath hold and the kind of where a patient can't manage breath hold, because of course some lung patients cannot. We've more recently been working on gating. So we had never done that with RPM or RGSC. So we were very excited to have the opportunity to work with Vision RT on the respiratory module. I installed a test system of that in January last year, and then helped do some kind of initial measurements and validation testing. And that contributed towards the CE mark. This came in December last year, so just under a year ago. And then in February, we were actually the first in the world, which was quite exciting, to use the respiratory module. And as a first step to allow our staff to get used to it, we did that with backup gating, so you can see the wider margins there, just either side of the breathing trace. And then this was on a limited clinical release, and we were kind of collaborating really closely with Vision RT on kind of fine-tuning that as we did our first patients. And then currently we're introducing 4D cone beam and get our staff up to speed with that, and then we'll be doing the proper prospective gating and reducing the PTVs. Another aspect of lung treatment, well, Sabre SBRT lung, that has been really valuable for our patients is in the dose reduction. I mentioned it earlier. So when we first started Sabre lung, we were doing a cone beam, then one arc, and then a cone beam midway through, another arc, VMAT arc, and then a final cone beam. So that was 3. And then because we, around the same time of starting Sabre treatment, introduced SGRT, and we also introduced flattening filter-free treatments, we got rid of 2 of those cone beams. So we've massively reduced the dose to the patient and had a good time saving there, especially with the triple F combined with the reduction in imaging. So a colleague of mine, Charlie, is doing this trial, which he's actually going to use SGRT for some of that. And it's a trial looking at anxiety in patients. And he's translating some work from some American teams who have used physicist-patient interactions to try and reduce anxiety and help the experience be better for patients. So the reason that I'm mentioning this on the SGRT webinar is because he's going to use SGRT to try and quantify the anxiety of the patient and how much are they moving through the treatment. And it's just one use of many that you can do with the very detailed real-time deltas that as they're being treated, you've got millisecond by millisecond really information on the patient position. Another application could be PTV margins. And then another thing that's been really fantastic for our patients is the maskless radiotherapy. So we had one patient who was claustrophobic and would have refused treatment, and then we ended up treating them with a vac bag on a weekend. This was, and our previous patients have always been with these closed shells, and we were initially looking at the kind of traditional open mask, the letterbox, but then we actually introduced these macromedics ones, and they're just the back piece there. So this is a colleague in one, and they're far, far better for the patient than those traditional closed masks. So just to wrap up, I think we're a little short on time. Sorry if I've gone over, but SGRT is an absolute necessity. It's not like a nice extra. And choose your system very carefully. Think about your applications. It's new technology still, so a tried and tested solution is quite wise, I think. Learning from others is really valuable. Webinars like this and asking for help from others. The QA is quite unfamiliar initially, so make sure you've been trained beforehand. We've had exceptional support from Vision RT, and it's a rapidly evolving area, so R&D investment is really key. So yeah, we're going to have questions at the end, but my email address is there if anyone wants it. And I just mentioned R&D, so it transitions nicely into Mike's talk, where he's going to talk about some of the newer stuff that's been coming out.
All right. Well, thank you, Josh. As I share my screen here. So good morning for me. I see a lot of good evenings as well in the chat. My name is Mike Tallhamer. I'm the chief phys for Advent Health, which is a health organization here in the US. And I'm based primarily out of Denver, Colorado in the West. And I've been asked to talk about the impact of SGRT across the entire radiation oncology workflow from simulation to delivery. So we are an institution. Before we get started, these are my disclosures as far as this is our institution here, how we span the US. We have a couple PSAs and COE agreements with Vision RT. And then I'm also a physics consultant with various vendors of technologies that you'll see in this talk. But Advent Health believes in SGRT to the extent that we have made SGRT our standard of care. Our standard of care across all treatment, we'll say, stops along the way. So everything from simulation through our alignment, setup, and now dose visualization is all handled by an SGRT technology. We treat 100% of our patient census across all body sites and all indications. That's heterotropic bone ossification, palliative bone mets, osteoarthritis, all the way up to trigeminal neuralgia, AVMs, essential tremor, everything you can think with SGRT. We don't mark our patients. We treat massless head and neck, SABR treatments, and a number of other things across our institutions. And we rely on SGRT, as Josh was saying, as that technology to deliver that precision on a daily basis to each one of those patients. The way that works is we have various different technologies, and we've standardized on the Vision RT technologies because they provide us a single vendor solution throughout the entire workflow. We use SimRT, their product for 4D CT simulation, and breath hold coaching at CT Sim. We use a MapRT product, which we'll talk about here in this talk pretty extensively, about clearance mapping and non-coplanar planning, or we call it surface-guided planning in our institutions. We're using that to ensure that there are no collisions with our non-coplanar planning, and also optimizing the delivery of our treatment plans and making sure that they're most efficient before they reach the machine. With the introduction of our Halcyon units, we've introduced the AlignRT big bore in-bore systems that allow us to monitor the deep inspiration breath hold inside of the bore, not relying on the limited field of view of external cameras from other systems. We have an external system for setting them up, and then we also have this internal ring bore system that allows us to monitor the breath hold inside of the bore itself. And then on our C-arm Linacs, which are also Varian Linacs that Varian TrueBeams, we system, which is the traditional sense of what everyone thinks SGRT should be for both motion management and for patient setup and for respiratory gating, as Josh touched on all of those topics. Introduced the Cherenkov imaging system called DoseRT, which exploits the Cherenkov effect, which is an effect we get for free when we irradiate our patients. Our patients emit light from the irradiated area, and these intensified cameras allow us to pick up that radiation by gating them to the beam pulses of the Linac. And so we will explore a lot of these things as we go through. But talking about AlignRT, as Josh kind of touched on in his talk, it is a series of modules. So we use the patient identification module, which is the facial recognition system that interlocks the patient's treatment to the biometric signal of the patient. We use the postural video that you saw in Josh's talk as well, and 100% of our patients. This is, I believe, one of the greatest advances in patient setups in the last 15 years of radiation therapy. Respiratory module, as Josh said, we also have this for phase-based gating, and you can even use it for the breath hold technique if you don't want to use the standard respiratory module inside of posture or the respiratory function inside of AlignRT. And then we have newer modules, things like the OIS module, which we'll touch on at the end, which is a automated documentation system, which is really important here in the States, but also abroad for documenting our process and how we use SGRT, because as Josh stated, it is somewhat unique to the radiation oncology workflow. We've also added the beam guide system that Josh touched on, and we'll talk about some of the synergies of the beam guide system with the DoseRT Cherenkov imaging system and how those work. Beam Guide is 510K pending in the United States, so it's not actually available for clinical use yet outside of research institution. And so we are using this in a limited capacity, but are excited to get the 510 clearance later on or early on in 2026. So the goals are simply to discuss the SGRT technologies at every step of the radiation oncology workflow. We'll touch on those technologies in sim plan, treatment, and dose visualization. We'll talk about the usability and effectiveness of the two newer products, MapRT and DoseRT, because they're a little less well known because they haven't been in the field for as long as AlignRT and SimRT. And then we'll hopefully give an overall perspective on what an end-to-end SGRT workflow can look like and how it can benefit your practice overall. Starting in CT, so we're just going to kind of follow the path of a patient through our simulation process all the way through treatment as we go through this talk. But when we were looking at introducing SGRT for simulation, we polled our clinicians and our therapy staff and wanted to know what was the most important features of a 4D CT simulation technology. And these are basically the top 4 things that came out of that. That it should be able to accommodate different treatment position and patient anatomies. That seems to make sense. Should be non-invasive and contactless. This has been even emphasized with the COVID issues that we've had back in 2020. It should not compromise the physician's treatment and or immobilization strategy, which is somewhat common with other solutions. And then it should be easy to use and learn with simple workflows that are designed around a clinical process, not around a software development process. So SimRT was added to our institutions back in 2014 when it was actually called Gate CT, its predecessor technology. And we found that the clinical staff determines all the optimal positioning and immobilization strategies for our patients. There's no apparatus to put on or in our patients. We think of a contactless setup being optical versus something like RPM where you have a block, or the bellows system from Philips where you have a belt, or the Anzai belt, or even the spirometry systems like ABC that go in the patient to kind of control the respiratory cycle. So this is a completely contactless system. There's no sanitary issues, but it also limits the impact it has on those immobilization strategies that the physician is ordering at the time of consult. All coaching is done at the patient bedside. We felt this was very important because we can actually provide real-time instructions. We can provide real-time coach visual instructions. So there's a visual aid that goes along with the SimRT system. And you can also provide tactile instructions. So if the patient is arching their back, you can interact with the patient much more readily at the bedside using the in-room monitors and the live feedback that's happening both for the patient and for the person doing the coaching, whether it's a therapist or a CT Sim Tech. And then the simple intuitive interface can be pre-configured by your physics teams. This allows us to increase efficiency and cut 20 to 30 minutes sometimes off of a 4D CT sim. And that's because we can pre-configure our protocols to match the protocols on our CTs. This allows our CT sim techs, instead of spending a lot of time entering protocol parameters and setting up the system, it's more of a patient-focused workflow where we can work with the patient, leave the room, stand at the console, and allow us to do the CT sim for the simple control left mouse click functionality, rather than trying to set up cameras, set up blocks, put belts on the patient, do a lot of the other things that some of the other systems required us to do. This system largely took over our network after about 6 months in the field. We had such a demand for 4D CT sims being done because of the quality of the 4D CT sims on the single system that we installed. We removed all other systems and have replaced all 9 of them with SimRT systems. What this looks like for a DIBH workflow, very simple. You take a reference image and place a respiratory tracking patch. That respiratory tracking patch acts just like you would think an RPM or RGSC block would work. You turn it on, have a set of dotted lines. This is telling you that the system is learning, and it will tell you that it is learning the breathing trace for the patient. Once that breathing trace is learned, the line goes to solid, telling you it has a predictive model for breathing. And then you can easily use this in any DIBH or breath hold scenario that you like. This is a breathe and hold pattern at inspiration. You can use breathe and hold at expiration. You can do deep inspiration breath hold, which is very common for breast and saber treatments at our institution. Or you could do deep expiration breath hold, which is often used for liver and a number of other indications in and around the diaphragm at our institutions. Very easy, very quick workflow. There's one screen to deal with. You're not moving between modules. You're not moving between setup screens and tracking screens or anything like that. Everything is presented to the user in one simple interface. For the 4D side, this is a speed ramp video. You'll see kind of how the model works. You capture a reference surface. place the respiratory patch with control left mouse click, and you'll see the learning phase. This patient will cough, and you will see a warning pop up. It's very quick to let you know that it's going to need additional breathing cycles to continue learning because of this abnormal breathing. Once it gets the breathing cycles and predicts the model, the line goes to solid, and then you'll start seeing these inhale tracking points to let you know that the model is working correctly. Once the model is working to your satisfaction, you can simply turn on the beam. This is actual seconds down here, so even though this is a speed ramped video, you can see all of that happened in under 60 seconds. It's very, very quick. When the beam is on, you can see the patient is moving into the bore and the CT is being acquired. Is vendor agnostic. It will export a VXP file to any vendor, Canon, GE, Philips, Siemens, Toshiba. If you have it, they can export to it, which is really nice. The editing tools in here are fantastic, but if you have your favorite vendor editing, if you really enjoy editing an AW workstation, all of that can be done outside of the system once the CT is complete and the trace is exported. So they make it as simple as possible. They really reduce this. This 4D CT, the actual CT portion of this, is less than 3 minutes is what you're watching. Very efficient workflow for your 4D CTs and can really help a very busy clinic like ours that has a lot of throughput that it needs to put through their CTs, avoid delays in CT simulation for these safer patients. From CT, we move into treatment planning, and we've largely been using predictive models for our treatment planning in the past, but we have moved to MapRT, which is a patient-specific clearance mapping software. And what that does is it has 2 cameras in the CT sim that captures what we say everything above the couch, so the patient plus the immobilization, and allows us to do a clearance map for that patient and allows us to plan much more non-coplanar arrangements in a much safer way. And so it provides us with these clearance maps. These clearance maps can be used in the CT sim room to better set up our patients so we can use patient arrangements that are much more conducive to highly conformal treatments, and we can know that before applying CTs to our patients, so reducing the amount of exposure they see. We can use it as we use it about 95% of the time in planning to optimize our planning, and then we can implement to actually replace a lot of the virtual simulations that we do so that we can do our clearance checks and our collision checks offline in a virtual setup using the MapRT system. And the way this is accomplished is essentially the 2 cameras are calibrated using an epipolar calibration technique similar to what you would see for AlignRT or any of the other vendors. That establishes an external reference geometry that then allows us, when we capture the patient's surface above the couch, to register that in a coordinate system that we are aware of. Every CT vendor has a DICOM origin transform that sets the DICOM coordinates for your CT, and that is an internal coordinate system that you would give to your installation FSE, who's in RT system. He'll know what vendor you're using, and then the system is configured for your GE scanner or your Siemens scanner or whatever you happen to have. That transform between optics to DICOM origin allows you to do things with your clearance mapping software. So in this case, we're taking a surface captured for a spine SGRT, and we are registering that with a room geometry. That room for us is a true beam in the mid position, but if we wanted to use triggered imaging for this patient, we could simply take a different machine geometry. So this is the standard triggered imaging orientation for the true beam with the panels at 150. But we could also say, well, we want to do more couch kicks with this triggered imaging, so we need to move the panels back. And so we can simply select a new room geometry. And all of these are pre-configured by your FSE at the time of installation. So if you have an Electa or you have a Varian, all of these things are selected by the user and imported into the system for you to use and register with your patients. When you're in the collision or the clearance mapping screen, you have access to the isocenter, any couch indexing, the total plan quality. So in this case, this plan fails because field 9 is failing. We have passing fields. We have transitionary cautions, meaning you're going to pass through to move from field 5 to field 6. And then you also have failing fields, this field 9, which happens to fail because it's sitting in a collision zone. What you're watching is one of my dosimetrists optimize the delivery to make sure there's no unnecessary couch or gantry motions in between fields. You can see in the upper corner, you have buffers. You can add additional safety buffers to both your patient and your machine so that you can add some spacing between them. You have arcs, you have static fields, you have start positions and end positions. You have the collision areas that you want to avoid, and then you have a 3D geometry view for the room. So this gives you a global view of a plan long before the patient actually arrives for any type of verification. And so what this is allowing us to do is flatten the learning curve for non-coplanar planning at some of our institutions that are not familiar with this, especially our dosimetrists who are not familiar with doing these types of plans in other regions. This is a lung SGRT shortly after we got MapRT at one of our satellite institutions. They had a dosimetrist who's not familiar with non-coplanar planning, was finding it difficult to actually meet the constraints in the coplanar plan for the heart, the RTOG conformity index, the max dose gradient, and a couple of the heart constraints. We recommended that they use a 40-degree table spread. That's what we typically like to achieve for our lung SBRT or SABRE patients. And they placed this into MapRT, and you can see that a standard plus and minus 20 caused the collision. So they actually had to offset this 40-degree table spread by 5 degrees to the negative side. So basically just kicking to the 270 side just by 5 degrees. They were able to achieve that 40 degrees table spread, and with no additional optimization parameters, they were able to meet all of the constraints fairly easily, but also significantly reduce the chest wall V30 dose. So this is not a complicated technique. It's not a very aggressive technique, but it is something that saves a lot of additional dose and chances for toxicity for our patients, and doesn't increase any of the treatment time by simply being able to optimize these plans before they make it to the treatment machine. Think of non-coplanar planning for SRS. We do an extensive amount of SRS at our institution. These are highly precise, highly ablative procedures. We treat in usually 4 to 6 arcs. They're of high degree of likelihood of collision if you're not very careful with your planning. Some vendors like Varian have introduced HyperArc, which is kind of an aggressive way of reducing the chance of collision by completely eliminating all of the solution space and limiting it to exactly one solution space. So you have one beam arrangement that you can deliver. You have to use a very set of immobilization, and that allows you to essentially do this with high degree of certainty you aren't going to collide. But that doesn't always produce the highest quality plan. So MapRT allows us to explore the entirety of the solution space and still have the high degree of certainty that we are not going to collide with our patient. You think about a single isocenter multi-target plan like this is a much preferred orientation over HyperArc. You're not arcing through the eyes, for example. In this case, you would say, well, maybe you don't need MapRT. I think this is fairly safe based on my knowledge of the immobilization. But if you take the same patient who comes back 6 months later and needs a 4 isocenter, 17 arc, synchronously optimized SRS for melanoma, this is a significantly more difficult plan to visually kind of mentally work through your collision map. So MapRT makes this extremely quick by allowing us to integrate it directly into our treatment planning system using an API. So what this allows us to do is check one isocenter. If it's great, we're optimizing another isocenter at the same time. We can check that isocenter. If there's a colliding beam, we can change the parameters directly inside of Eclipse or RayStation, whatever you're using, and change that parameter on the fly as we're doing our work using MapRT, and even explore the solution space inside of MapRT inside of the treatment planning system. This allows us to cut about 30 minutes per isocenter off of our planning because we're not doing any export or reopening or moving out of any specific software to another. This allows us to optimize these plans right inside of Eclipse with no motion required as far as the dosimeters moving between workstations or moving between software packages. It also lets us validate our collision checking. You can see the DICOM surface, which was CT scanned. You can see the size of the MapRT surface and their fusion using the API. What we want to avoid is something like this, where we have a DICOM surface that was scanned for SRS. We have a very large MapRT surface that we have to worry about shoulders and arms, but they're not aligned. And if they're not aligned, that means in one case we can use the clearance map, in one case we couldn't use the clearance map. The API allows us to correct this situation directly inside the planning system so that this clearance map then becomes valid, and we don't have to bring the patient back. We don't have to capture any new surfaces. It really increases the efficiency, but also decreases the amount of times we have to intervene within our workflow to actually get usable data. So the API has been a lifesaver. We absolutely love the API and have written a number of applications that are open sourced out there for you guys to use. Moving on to treatment, we have Aligner T. We have just a few more minutes left here. Aligner T, we talked about in the previous talk with Josh, but this is, again, via the modules. We have patient identification, postural video for markerless treatments, deformation view for checking changes in patient anatomy, weight loss for head and neck or GYN patients, motion management, respiratory management, and what we really like as a physics team is the sub-millimeter accuracy entire body surface. If we commission this for SRS, we're getting that sub-millimeter accuracy from head to toe on every single patient, no matter what the indication we're treating. So the interesting part of delivery now is we have a DoseRT product, which is the Cherenkov imaging product, which allows us renderings of the entrance and exit doses to our therapist. They can view the delivery live on the patient. So if anything was to go wrong, the patient moves, we can see the consequence of that during delivery. And then we can sum all of these images together and get a composite delivery for physics review or for physician review to make sure that we're delivering the dose to the patient as intended. It allows us to capture things like this. This is an errant port film on this patient. They mistakenly added a pelvis port film to this 36-year-old female, which ended up delivering 2 monitor units through a 40 by 27 field. Because we are trying to treat this person in breath hold, we're trying to reduce the dose to her heart, to her contralateral breast, and to her lungs. And doing this every single day to verify a block would have actually ruined our DVH in that case. And so it allows us to capture these things, these errors that happen after physics check when we're assigning port film techniques by selecting it from a dropdown by mistake on the OBI. And so this is a very good kind of last end of the line intervention in our patient treatments. It allows us to do things like retreatments with certainty. So this gentleman received 55 gray to his entire upper lip. You can kind of see the irritation of his lip and his cheek. And now he's returned for nasal tip and inner septum treatment. This allows us to provide these renderings to our patients or to our therapist and allow them to make sure that we're avoiding the previously treated areas. This is a compliance issue that was caught. This patient is crunched up, like doing a body crunch, pulling on the hand grips. She's dipping her head down into the treatment field, and this was seen during delivery. So we stopped the delivery, and actually on the composite, we can actually see that there is dose to the chin. They went in to discuss her compliance as far as keeping her chin up to make sure that we were not exposing her chin. And while we were doing this, physics also noticed that she was pushing some of her breast tissue out the inferior border of the field. And because of this, we couldn't guarantee her compliance every day. So we actually took this plan back and dropped this inferior border to make sure the plan was robust to the compliance profile for this patient. This is a retrospective analysis of a inner thigh sarcoma. So a sarcoma of the inner thigh on the right leg. The left contralateral limb needed to be outside of the field. We were using avoidance sectors and no entrance, no exit structures to optimize this plan. And because the therapists were new at using postural video, they were focused primarily on the affected limb, which we would hope to. But because of the planning technique, we needed to make sure that this limb also stayed in the right position. We saw 4 fractions where this leg actually creeped into the field, resulting in different extents of entrance and exit dose to that limb. So now we can actually increase our quality assurance by making sure that we communicate that planning technique to our radiographers and our therapists to make sure that they're paying attention to the contralateral limb as much as they are to the affected limb. And finally, here's a prone breast. This is a prone breast where the first 2 fractions look like this. This is what we would hope to see. And on fraction 3, because she had back pain and had not taken her pain meds, she was trying to take the pressure off of her back by pulling her elbows inferior and trying to support some of her weight on her elbows. In doing so, she pulled the pad and her upper arm into the treatment beam. So you can see the Cherenkov signal coming off of both the pad and her arm. And we were able to address this, get her pain management under control, and allow us to treat her successfully. The question came up, though, is, well, if we didn't have reference images to say, okay, this is what we want, how would we know this was wrong? And so we introduce to our clinic this beam guide system. And what this beam guide system is allowing us to do is, if we were to see these 2 patients on day 1, we want to know, is this a planned exposure? Is this a overexposure because she's positioned incorrectly and that we're getting this posterior lateral chest wall and upper arm, or is this an underexposure because she's rolled constantly and we're underdosing the breast tissue or potentially some of the nodal regions? So each one of these, we need to know if this is a planned exposure, but we need some sort of a priori knowledge of what this is supposed to look like. And that is what Beam Guide delivers to us. So Beam Guide gives us an overlay in white of what the planned dose distribution should look like. And then in orange, we want to align the orange that's live updating. So in this case, we're seeing that, yes, the planned exposure is supposed to be this tight on the arm. And in this case, it's supposed to be very far back on the chest wall and into the upper arm. And so as we're setting this up, we have information about the treatment plan. And then when we're seeing this with dose RT, if the patient was to move, pull her elbows down, we would see in either dose RT the consequence of that non-compliance, or during setup, we would see that, yes, this is the intended dose profile that we should be seeing. So it's a great additional tool to give context to what we're seeing in dose RT, and it also gives confidence to the therapist that if they're placing bolus, they're placing it over the entire irradiated area. So it is a very, very useful tool in the clinic. We are very excited about potentially having this clinically by the end of the year. And so just highlighting these regions, these are the regions of concern that we would not know without the Beam Guide system giving that information to us. And our last thing we'll go through before questions is just a review case. This is a very complicated retreatment case. We did a thymus treatment to 55 gray. We're now delivering 50 gray to bilateral chest walls post-mastectomy. So we have a lot of removed tissue that was previously irradiated, but we also have central tissue that we have to account for because we do not want 110 gray hotspots in this bilateral chest wall VMAT. You can see the amount of arc passes that are required to cover all of the volumes that the physician has contoured. This requires us to use MapRT to make sure that we're not having excessive collisions, because you can see how high her arms are. The variant tubing that we have at this institution has an HDMLC, and we synchronously optimized both of these isocenters. So we know we need a 3 millimeter to 1.5 degree rotation to make sure that we have a good dose uniformity and no overlapping hotspots. And we also have to, unfortunately, with this plan, apply bolus to both chest walls during delivery. So this is a very complicated treatment that is somewhat hindered by the TrueBeam platform, because you cannot treat two isocenters synchronously in the same plan on the TrueBeam platform. So we use SGRT to address the limitations. So we set up this patient schematically with a free breathing breath hold surface. We have them breathe to the breath hold surface. Because we have two isocenters, we need to do a cone beam CT that encompasses both isocenters at this point. So we're doing a couch centering and a breath hold to transfer the breath hold information to the couch center position. We then couch shifts from the cone beam CT to align both isocenters at the same time, and then apply the shifts at the isocenter position. So transferring that information back to isocenter using SGRT. And then we actually have them take in a breath hold, place a bolus, take a new reference because we need breath hold with bolus. And so we're going to treat them with bolus breath hold for the first isocenter. After the first isocenter is treated, we need some sort of isocenter transition of moving the 6-DOF corrections from one isocenter to another. That is currently not possible on a TrueBeam. So we have to use SGRT again to maintain the setup under breath hold from one isocenter to the other. There's two strategies. There's a manual strategy and a automated strategy. The automated strategy comes with some challenges if you're using a 6-DOF couch. So in this case, we chose the manual strategy. The manual strategy was to manually move both all 3 degrees in the vert lat and long using SGRT to guide us. We then take an IGRT under breath hold at that new isocenter position. So using SGRT to get to breath hold to make sure that we have successfully transferred that couch information. And then we are again placing bolus, taking a reference, and using that bolus reference to deliver radiation to the patient. This is a somewhat benign type of treatment. We know we can treat chest walls, but when we have complexity like this, we've added a number of steps that SGRT has to answer. And some of the questions, can we use SGRT to validate checking this position consistently historically from day to day? How do we know that and validate that what happened at the machine, if we're not standing there as physicists or as physicians, happened in a way that is conducive to the level of complexity that this plan demands? And then how can we document the value of what we're doing with SGRT to make sure that it's happening the right way every day and that we're not getting these overlapping hotspots in this patient? If we were to look at this in traditional ARIA, you would see a cone beam CT, a shift, delivering of the right chest wall and superclav treatment, and then a shift to a new position, a verification image, and then a treatment of the left lateral chest wall. That does not take into account every one of these red arrows. Every one of these red arrows represents an SGRT step that must be executed and executed almost flawlessly to within 2 millimeters of precision. And so how do we document something like this? Well, For accreditation, we're used to having an IGRT workflow inside of our OASs where we have approval of images with the physician who approved it and a timestamp. And so what we've added is the OIS module, which just adds these additional SGRT timestamps into our ARIA timelines. And what that gives us is a way to validate before this patient was treated and in breath hold, we know that she breathed into breath hold, into tolerance. We also know that we had beam gating turned on so that if she was to breathe out, these would be turned off. And then if we want to track every single step, we can look at every session. So if you have multiple isocenters, you can look at a DICOM report, all within a very familiar IGRT workflow for our physicians. There's no more hunting down PDF documents and did the wrong document get imported into the wrong patient. This is all automated. So as soon as you close the session, this information is available in the OIS. That's very important for our SRS patients that have multiple couch kicks and very high precision treatments. So here's a partial brain that's getting multiple couch kicks. We can see that they're in the 1 millimeter, half a degree tolerance before the first beam. And then before the second beam, and then before the third beam, they stayed in tolerance for the entirety of the delivery. And if we want to validate that they were in tolerance the entire time, we can check the report. If this person had 4 isocenters, you'd have 4 monitoring sessions, and all of the information would be right inside of the IGRT workflow for their physicians. So in summary, the end-to-end SGRT approach for typical radiation oncology workflows is both practical and beneficial. The new technologies, MapRT and DoseRT, are adding an unbelievable amount of utility to our SGRT process and an ability to intervene with our treatment plans in ways that we couldn't before. Implementing new clearance mapping technologies has broadened the capabilities of many of our centers to do more non-coplanar planning, increasing the benefit to our patients and increasing the availability of SABR-type treatments to some patients with very challenging body habitus. And the real-time dose visualization is allowing us to interact with our patients in a new way that is not increasing the exposure to the patient, but allowing us to intervene on their behalf on a day-to-day treatment basis. And finally, we're integrating all of our documentation. We're now promoting SGRT into that IGRT workflow, allowing us to eliminate any documentation errors and maximizing, at least here in the States, our future reimbursement potential by documenting the management of these patients in a more complete way. And so with that, I'd like to thank my physics team, Adi Robinson, who's one of our physicists who also has this in the Florida market, who helps us with our data collection, and Josh, who has been invaluable with the respiratory module. And then I think we are opening this up for questions at the end here.
We are, and we are actually at time. So really big thank you to both Mike and Josh for their presentations today. Lots of insightful information and hopefully a lot of food for thought for those that have joined. Josh has kindly been answering all the questions online as we go, so that we didn't miss any of those. So Josh, appreciate you answering those. I think we have been told we do need to wrap up on the hour and not take too much time. So perhaps Mike, there's one outstanding question we could. It's about dose quantification, missed doses to plan fields due to daily positional variances. So I don't know if it's easier just to type an answer to that, or if it sounds quite complex. It sounds like it's maybe not a quick answer.
Yeah, it is not a quantified dose technology. So the simple answer is no, you can't use it because it's not giving you pure dose information. It's giving you Cherenkov signal. So that's the short answer to that question. It would maybe in a future application, but it's not available yet commercially.
Great, thank you. Okay, so I think we're going to have to wrap up, but yeah, again, Josh, Mike, thanks so much for that. If people have got further questions, then please do go to sgrt.org, where we have our full SGRT community, where there's a forum, so you can post questions and our experienced users will get back to you there. And there's publications, posters, resources, guidelines. All our upcoming webinars are on there, so that's a really good place to go if you have any outstanding questions. So yeah, thanks to everyone for joining. Big thank you to Mike and Josh, and I hope everyone has a lovely weekend when it gets to you. Thank you.